Thank you, committee. Today is Thursday, January 9th. This is the first Senate Finance Committee briefing. Today we're going to hear on the Prescription Drug Affordability Board, and Dr. York is here with us, Executive Director. Thank you very much.
Great. Chair Beidel, Vice Chair Hayes, and members of the committee, thank you very much for your time today. And I can't say what an honor it is to be your first briefing for the session, so thank you for the opportunity to speak to you today. My name is Andrew York, and I am the Executive Director of the Maryland Prescription Drug Affordability Board, and I'm here to provide an update on the work that the board is doing and answer any questions that the committee may have. There's 4 topics I was hoping to cover today. One, just give an overview of the Prescription Drug Affordability Board, especially for folks that may not be familiar with our work. And then we have 2 big projects that we're working on right now. So I was going to provide an update on the cost review process and also an update on our policy review process and upper payment limits. And then finally, the committee was interested in the expansion of the Prescription Drug Affordability Board Authority and the report that we'll be doing on that topic. So just for your reference, the board was created in 2019. We are the first in the nation in Prescription Drug Affordability Board. And in Maryland, we are an independent state agency dedicated to making prescription drugs more affordable for Marylanders. We have a 5-member board supported by a 26-member stakeholder council. And I always like to include the purpose of the board because it kind of articulates exactly what we're supposed to be doing. And that's protecting the state residents, state and local governments, commercial health plans, healthcare providers, pharmacies licensed in the state, and other stakeholders within the healthcare system from the high cost of prescription drugs. We have our 5-member board, and each member needs to have a background in medicine or economics. And our chair is a previous legislator, Chair Van Mitchell. And then we have 3 health sciences researchers, Dr. Joe Levy out of Johns Hopkins, Dr. Jerry Anderson out of Johns Hopkins, Dr. Stephen Rockhauer, a retired physician, and then, Dr. Aberia Nukuga out of the University of Maryland School of Pharmacy. So again, an extremely experienced board who's been doing this work for a long time now. We have 3 priority projects that we that we're working on. Our legislation calls for us to do something called cost review studies. And basically this allows the board to do an in-depth review and study of certain drugs to determine if they cause affordability challenges. And one of the big challenges in the prescription drug space, and I think this is for healthcare overall, is kind of the opacity and complexity of the system. It's a very complicated system, and all the pricing basically sits in this black box that no one can see into. So what we see is often very high, what we call gross spend, that insurers pay to the pharmacy, but then on the back end there are these rebates that get you to a much lower net cost. So no one knows what those are, no one can see what they are, and often that is the determination of if the drug is affordable to the healthcare system or not. So ultimately, as part of this cost review process, we kind of get to look under the hood and try to understand if the drug is actually unaffordable. The next thing we can do as part of our legislation is something called upper payment limits. And this isn't a policy tool to address some drugs that cause affordability challenges. I'll go over something called our upper payment limit action plan and then our proposed regulations that actually articulates exactly what an upper payment limit is. But that's one of the tools we have in the toolbox to address drugs that may be unaffordable. And then finally, we also hope to be subject matter experts for any policymakers, including Senate Finance, to help work through some of the very complicated issues in the prescription drug supply chain. So we want to be a resource for you, and then also our board may make specific policy recommendations as part of an annual report that they do. So the first thing I'll go through is just a general timeline of our work. So you'll see that we've been around since 2019, but we had kind of a slow start. Our board was appointed in that first year, and then we had funding legislation that basically gave us the funding to do our work was passed in 2020. That legislation was vetoed, so then there was a veto override in 2021. So our real work really didn't begin until 2021. And then since then, we drafted something called our supply chain report, and that is basically supposed to be an explainer on all the issues in the prescription drug supply chain and some of the challenges in in that specific market that we may need to address through certain policies. Next, we developed something called we developed the cost review study process that required the passage of regulations that basically created that process. In 2024, we actually started implementing the cost review study process. So we've started doing the cost reviews study on 6 drugs. And then we also developed our upper payment limit action plan, which was approved by the Legislative Policy Committee. And in 2025, we're just really excited to move forward with all this work. So we expect to conduct our cost review studies, and for any drugs that are deemed unaffordable, conduct our policy review process, which I'll go over in just a moment. So the cost review study, as I mentioned, it's our chance to kind of look at specific drugs and kind of look under the hood. So there's 5 main steps to this process. There's the identification process, the selection of drugs for the cost review study, data collection for those drugs, analysis of the data that we collect, and then ultimately the results. And I'm not going to go through each of these steps, and I'll just because it can be its own process, but at a very high level, our legislation and regulations that we passed make about probably 2,000 different drugs eligible for a cost review study. And obviously, we're trying to focus our resources on drugs that may have the largest challenges to the healthcare system. So we have a process for selecting drugs from that much larger list. So it's a list that goes to the board. The board then nominates certain drugs that they're interested in feedback on. We send that over to our stakeholder council, which is our kind of public, they're the subject matter experts representing the different parts of the supply chain. And then that information goes back to the board and they ultimately select their drugs. We've selected 6 drugs as part of that process. They're listed on the screen: Farxiga, Jardiance, Ozempic, Trulicity, Dupixent, and Skyrizi. This is for the first round of cost reviews. Once those drugs are selected, we do something called our request for information, where we reach out to different stakeholders in the group: the manufacturers, PBMs, pharmacy benefit managers, insurers, and wholesalers, to gather more information on those drugs. All that information comes back to the staff, and we analyze those drugs. The staff presents that information to the board, and then the board ultimately makes their determination on if the drug causes affordability challenges or not. So that's the process that we're working through right now. We've collected the data on the first 4 drugs, so we expect those cost review study processes to occur, hopefully sometime this spring. And then for the second 2 drugs, we'll issue a separate request for information, then we'll conduct the cost review study for those drugs once we have that data. So then that brings up the question of what happens if the board determines that a drug is unaffordable. We have the authority, our legislation created the authority to do something called upper payment limits. To enact this authority, we had to submit something called our upper payment limit action plan to the Legislative Policy Committee. And this was basically an explanation of how we plan to implement upper payment limits. So it was a multi-year process to develop the framework for how we would implement upper payment limits. And ultimately, the board approved the upper payment limit action plan in our September 2024 meeting. That action plan was presented to the Legislative Policy Committee in October, and it was approved. And now we're in the process of passing the regulations to implement that process, and then ultimately we should be able to go through our policy review process starting hopefully this spring. I know I'm throwing a lot of very technical jargon out, so please feel free to stop me and ask any specific questions that you have. So the upper payment limit action plan is going to be implemented through 3 sets of regulations. We expect those regulations to be published in the Maryland Register on I think as soon as this week, potentially January 10th. These are going to be the proposed regulations, so they'll be open for a 30-day comment period. So if you do have any stakeholders or constituents that are coming to you, this is a great chance to kind of weigh in on this process before it gets implemented. And then ultimately the board will pass final regulations that would set up the process. And I think just at a very high level, what the upper payment limit action plan does is sets up a very robust process to implement the policies that we think can address affordability challenges. So the first step is for the board to make what we call our preliminary determination of an affordability challenge. So based on the data that they have from this cost review study process, they can say, we believe that this drug is causing affordability challenges. And then this opens us up to what we call our policy review process. And this policy review process has 3 main steps. One is gathering additional information. Then our staff can make recommendations on specific policy options. And this is kind of where there's like a fork in the road. We have non-UPL policies, and then also the board can, or board staff and the board itself can recommend setting an upper payment limit. I think one of the big things that we try to emphasize here is that, again, an upper payment limit is a tool in the toolbox, but we are equally weighting other policy options that can address the affordability challenges. An upper payment limit may not be the right tool in every circumstance, so that's something that the board actually needs to proactively decide. But then if they do decide to move forward with an upper payment limit, we have a very robust process on how we go about setting up and implementing that process. And then finally, after the staff recommends policies, there's a substantial public comment input, and the board can ultimately approve these policies, and this is through final action. They can either adopt determination, they have to adopt the determination of whether the drug causes affordability challenges or not, and then they can recommend their policies. So they can either adopt a non-UPL policy recommendation, or I guess they can do both. They can propose regulations setting a UPL at the specified amount. And the big thing to note here, the big takeaway here, is that we plan to implement our upper payment limits through another set of regulations. So anytime an upper payment limit is set on a drug, we would set regulations that say who the upper payment limit applies to and what that upper payment limit amount would be and how it's implemented. So there is an appendix. So this is where it fits into a cost review process. So originally, we just had this cost review study process based on our legislation. When we created our upper payment limit process, it kind of inserts itself after there's this preliminary determination, and this allows us to gather more information and propose policies that can help make the drug more affordable. And I have a diagram here just of the different steps. I did want to be sensitive to time, and you'll also see your presentation includes an entire appendix, so going through in detail all the steps that would be necessary to set upper payment limits. But just at a very high level, the board does their cost review study. They can make a preliminary determination. If they say the drug's affordable, we just create a final report that says the drug's affordable. If not, then we need to identify what makes the drug unaffordable. Like, what is the issue that the market failure that we're trying to address that would then make the prescription drug more affordable. Some of those, one of those policies could be upper payment limits, or there could be non-upper payment limit policy options. And then there's two different tracks. You'll see the green, and again, maybe hard to read. It's a very detailed process. But the green process is the process for setting upper payment limits. And at a very high level, and the takeaway from this is just that staff will propose different iterations of the steps. So the first thing we need to do is propose the general framework. So there's a number of ways you can set an upper payment limit. We would say we think we should go about it using a specific methodology. At each step in the way, there's ample opportunities for public comment, and then the board ultimately makes the decision, gives guidance to the staff. So just going through the steps, the staff recommends a methodology, public comment, board approves a certain way. Then the staff actually does the math and calculates that upper payment limit amount, publishes that amount with the methodology that everyone can comment on. The board approves that. And then ultimately it gets published as regulations, which will go through the standard Administrative Procedures Act procedure. So publish regulations for comment and then a final regulation. So just again, a very, very robust process. So I'm happy to go into the weeds on any of the specific issues there. The last thing we wanted to talk through is just the expansion of the Prescription Drug Authority Board. It sounded like the committee was interested in the board's work in this space. So on or before December 1st of 2026, the board and the Stakeholder Council will report to Senate Finance and the House Health and Government Operations Committees on the legality, obstacles, and benefits of setting an upper payment limit on all purchasers and payers in the state. And then also a recommendation on whether the General Assembly should pass legislation to expand the authority of the board. So that work is, the board has not published that report yet, but I will say that there are examples of states that already have the full authority. So I think there's at least 2 states that have the authority that's mentioned in this provision, and then there's also just other examples and frameworks of showing how this could work. Again, the board has not done this analysis yet, so we don't have any specific comments or recommendations in this space, but we're happy to answer any questions that you may have. And again, I'll just conclude by saying that the Prescription Drug Affordability Board hopes to be a resource for the Senate Finance Committee. There's a lot of very complicated issues in drug pricing, and oddly enough, there's always legislation around reimbursement and drug pricing. So we want to be a resource for you that can provide an unbiased explainer on how exactly everything will work. So with that, I'm happy to answer any questions that you may have.
Thank you very much for the presentation. Let's start with Senator Mounts.
Thank you, Madam Chair. Just a quick question, and I'm sorry, I'm just trying to refresh my memory on the subject matter. But this board, the prescription drugs that it's overseeing, those are just drugs on. Was it what's the limitation? What does it cover? All prescription drugs in the market, or is it just a group? I thought it was a group.
Yes, that's a very important question, and I'm sorry I didn't address that in the presentation. Our current authority for upper payment limits is for, we say colloquially, state and local government, but basically it's state and government purchasers. So the buckets of folks you can think of is the medical assistance program, or Medicaid fits within that bucket. Any direct purchases by the state, so prisons, any like hospitals owned by the state, that all technically fits within there. And then also any state, local, or county or municipal health plan. So you can think of employee health plans. So that's the current authority. And that report that we owe would move it to all purchasers in the state versus just state-specific purchasers.
What would move it?
The report that I mentioned on the last slide. There was a
It's
question
coming
about,
in 2026.
we owe the report in 2026, yes.
Okay. Was the report come before then, you think, though?
I don't think the board has set a specific timeline on it. I think we can always do things earlier. We will definitely hit that deadline. But right now, the board has not published that report.
Thank you.
Yeah.
Thank you, Senator. I'm sorry, was Senator Lamb next? Okay.
All right. Thank you, Madam Chair. Thank you, Mr. York, for that presentation. A lot that you went through there. I want to go back to what we oftentimes will hear in our office from constituents, which is, number one, that prescription drugs are too expensive. It's hard for them to afford to pay for this out of pocket. And two, that the drugs that they are on or need aren't covered by the formulary. To the first part, that they're paying out of pocket. And I know my colleague here, Senator Hershey, has touched on this as well, that if you were to put upper payment limits in to make sure that those cost savings are actually passed down to patients and consumers, that it isn't simply being a loss then in PBMs or in payers or insurance companies who oftentimes will then skim those savings. The patients then see nothing, in terms of what they're actually paying out of pocket. What can we do to help ensure that if those upper payment limits are implemented, that the benefits aren't just being reaped by PBMs and payers?
It's a great question. So thank you, Senator Lamb. So a couple different issues. When we set this is something that our board has spent a lot of time talking about. Our board has said that the ultimate mission of the board is to help patients in Maryland and make sure that the savings accrue to those patients. But one thing that we stumbled on relatively early in the process when we were talking about upper payment limits for state and local government is that the plans for state and local government often have nominal or patient costs. So the issue that you're describing is more prevalent in the commercial market than it is in the market that we are regulating. So all to say that any upper payment limits that we set for state and local government will likely accrue as savings to the state, which we think is still a value to the state members. And then where it is relevant, we will be able to pass those savings on to patients. So going to your question of how do you actually do that, there's a lot of work out there. So it would be how we implement the upper payment limits. You can say that coinsurance is based on the upper payment limit amount. So for example, one of the issues that you often see in this space is coinsurance is based on the list price of the drug or the gross spend of the drug. So you'll have situations, and then the rebates happen on the back end. So you'll actually have situations where the patient is paying out of pocket more than what the net cost is to the insurer. So that is, I would say, like a fundamental issue in how prescription drug reimbursement works. You can have you can have a separate policy that just says that patient insurance should be based on the actual amount that the insurer pays. It's almost a tangential issue, but I would say, or a separate issue or a parallel issue, but I would say that part of what we would be doing when we implement is including provisions that say any savings that come to the insurer should be passed on to the patients in the form of like a coinsurance, having the coinsurance based on the net cost of the upper payment limit versus the list price. So.
Is there any intention that you would see this moving to the private market, that the PDAB would also cover the private market?
The board hasn't taken a position on that yet. So the report that we owe in 2026 will describe how that could work, and ultimately I think we are supposed to put a recommendation in there. Right now, there are states that regulate their state-regulated private market, but that doesn't exist in Maryland at this point.
And then to the second part that I had, which is that we hear from constituents that say, my drug's not covered by the formulary, is there any requirement that for drugs that experience an upper payment limit, that the state plan, the state employee insurance plan covers those medications? Because, on one hand, if you put an upper payment limit in, but it's not on the formulary for state employees, well,
Right.
You're also not reaping the benefits.
It's a great question. So that's probably would need to be looked at on a case-by-case basis. Our state employee health plan formulary is exceptionally generous. It is a very broad formulary. So we do hear of cases where state employees may not have it on formulary, but it's often a very unusual circumstance. So, but I think in general, we would need to create some sort of policy where if the state is setting upper payment limits on something, we should figure out a policy for if it's not on the formulary.
Right, to cover it as a state.
Yeah.
Last question then is it sounds like you've been looking at how other states who also have PDABs are going about this. I presume that you're looking at other lessons learned from them when they set their upper payment limits, how we can do that and make sure that it's more effective so we're not redoing or coming across the same challenges that they are seeing in other states as well.
Yes, I think we're always looking at what other states are doing in general. And even just as an example, the framework that we're using for how we're setting or implementing upper payment limits for state and local government is based on how New York and Massachusetts Medicaid kind of works through. They have certain policies that they implement. So we're always looking at we don't want to reinvent the wheel. So we are trying to learn from different folks' experiences, and we'd certainly take that into consideration when we make any recommendations.
Okay, thank you.
Thank you, Senator Hershey.
Thank you, Madam Chair, and thank you, Director York. Just to follow up, I want to make sure I understand. We will not be getting a report from you until 2026, correct?
The report, we will be submitting a report by 2026.
By
So,
2026.
yeah.
Do we expect that report to come during this legislative session?
I don't think we have any. The board has not discussed any timelines publicly.
So there will be no recommendations from the board to expand upper payment limits?
This report will likely not be published. I mean, I guess the board hasn't set any timelines on publishing that report since it's due in 2026.
Okay. And then you mentioned, are there only 2 states that have done upper payment limits so far?
I think there's up to 2. There is at least 2 states that already have the authority to set upper payment limits for their full market. One is Colorado, and then Minnesota just created a prescription drug affordability board that has the authority to set it for the full state.
So when we met back in October, Colorado was going through a litigation, and it was pending at the time. Has that been resolved? Have we heard?
That litigation has not been resolved.
So
and
that's still outstanding. And Oregon, what have they done?
Their upper payment limit authority is not for the full state. They need to pass legislation to create it for the full state.
They haven't done that either.
Yep.
So is there anybody that has gone as far as we've gone so far that you've seen success from?
I think we're at the same stage as Colorado. So, well, we have not made the affordability determination, but we are passing the rules to implement upper payment limits for state and local government. So I would say that we are a couple steps behind where Colorado is. Colorado has deemed certain drugs to be unaffordable, and they're working through the process of setting upper payment limits for some of those drugs.
Okay. And obviously there's a lot of propaganda going on right now on how this is supposed to be aimed at out-of-pocket expenses and driving down the cost for consumers or patients or those at the counter. But I think we're hearing a little bit more that the potential savings are really passed on to the health insurance policies, the programs themselves. Is that more accurate?
I think that's an artifact of the fact that this is for state and local government, and our employee health plans are often copay based. So there is no, I think in markets that are co-insurance based, where the amount that the patient pays is based on the cost of the drug, there is an opportunity there. Those don't exist in our regulated space at this point.
So would those that are at the counter see a difference in what their cost would be?
The way that our prescription drug plans are structured is a flat amount that is not based on what the cost of the drug is. So for the patient, so specifically for how upper payment limits would be implemented for state and local government, it's a flat amount already. So there's, yeah.
So patients wouldn't see, they're not going to go up to, if they get one of these drugs that an upper payment limit has been set on, they wouldn't necessarily go up to the counter and see any type of savings.
Right. So for state and local government, it would likely be taxpayer dollar savings. It would be
Right. I think
reductions in
that's
taxpayer expenditures on
That's what we've
prescription
seen.
drugs.
So,
yeah.
and then finally, there was, again, a talk about a number of UPL policies. Again, if we're waiting for this report in 2026, are we not going to see anything from the board based on those?
So as part of so if our regulations are finalized, that creates something called our policy review process, and we'll basically be looking at everything that the state of Maryland can do to make a prescription drug more affordable for Maryland residents. And those policies aren't necessarily limited to state and local government. It's only our upper payment limit that is state and local government. Now, there is a question of like what kind of authority does the board itself have. So often what it's going to be is potentially legislative recommendations or recommendations to our executive branch partners on the implementation. But you can think of things like, for example, in, was it 22, you created an insulin copay cap. Like that's certainly like a policy that is on the table for something like this. So if we determine that, ultimately we think that the upper payment limit addresses a very specific market failure. And if that market failure doesn't really exist, we would look at other things to make the prescription drugs more affordable for Marylanders. So,
When you say for Marylanders, do you mean through, again, I want to make sure that we're talking about, do you mean for Marylanders when they go up to the counter and they see a difference, or do we mean for Marylanders in the fact, as you mentioned earlier,
Right.
it may save the government, state and local governments, it may save them money for having to spend on this, but that doesn't necessarily mean that there's any tax rebates and the citizens are getting that money back, right?
yeah, so it's confusing the way we have to describe this, but basically, if the board deems a drug to be unaffordable, and we look at it for all Marylanders, not just state and local government, there is a set of tools that the state has, not just the Prescription Drug Affordability Board, but the state itself has. And there's a whole bucket that can help all Marylanders. And then one of the tools in the toolbox is we can set upper payment limits for state and local government, right? So we are looking at all of the tools that are available. One of those tools could be setting upper payment limits for state and local government, which is a very kind of specific issue and a specific fix for a specific population. But we would make recommendations that says, the General Assembly should pass legislation that, protects patients in certain situations, right? And that would affect all Marylanders that are protected by the law. And then, we would work closely with our different executive partners, so the Insurance Administration, the Department of Health, they have different things that they can do. There's certain contracting things that the state can do. So there's a number of things that the state can do that would affect folks that are not state and local government UPL touched, right? There's everyone else, yeah.
Thank you very much.
But it is, I understand the confusion but we almost look at them as two separate buckets. The way I like to describe it is, again, this is a very specific tool that we can use, but everything else that we're doing is generally looking at the full state and all Marylanders.
Thank you very much.
Yep.
Thank you, Madam Chair.
Thank you, Senator. Senator Ellis.
Thank you, Madam Chair, and thank you for your presentation. Quick question, well, hopefully it's a quick answer. Does the board do any work with like Section 340B drug plans? And could you explain a little bit?
Yes. So we actually owe a report also in 2026 on some legislation that I believe was passed last year. We owe a report basically giving an explainer to the General Assembly on the 340B program. So we would like to be considered subject matter experts in that space. The report is supposed to look at how the 340B program currently works in Maryland, so kind of a descriptive analysis. And then the legislation itself was trying to outlaw a very specific practice without getting too into the weeds. Basically, manufacturers are required to give discounts to certain entities, certain qualifying entities, and the manufacturers were believing that these entities were not qualified to receive those discounts, so they were refusing to give those discounts. So Maryland basically looked at creating a law that would prohibit the manufacturers from refusing to give that discount. As part of all that, we're basically supposed to give a report that is an explainer, hopefully, for the state and also the General Assembly, explaining the 340B program as a whole, all the different issues that are faced in that program, and then also specifically what the implications of that law would be.
So that proposal will come from the board to us to put that law
I'm not sure
in?
if it'll necessarily have a policy recommendation. What we like to do is just provide all the information to the policymakers, and then ultimately the legislator would decide on how to move forward with that.
Yeah, because with that program, you know, as far as discounts not being offered, also the the constituent, the citizen, have to know where to go
Exactly.
to get some of these programs. And I believe we as a state, we're not doing our part to let people know, so they can go to one health facility and pay $5,000 for a treatment, but if they knew, they could go to another and pay $500.
Yeah.
And so are we doing anything as far as education for the discounts that are being offered?
Yeah, and this is one thing I meant to also refer in response to Senator Hershey. One thing we try to do as a board is we are a resource to all Marylanders. So if any Marylander comes to us, we try to help them work within the existing laws and programs to identify how to get their prescription drug as cheaply as possible. So a lot of things, and this I think is, again, healthcare as a whole, sometimes it's just very hard to navigate. You don't know who to talk to, you don't know where to go, you don't know what programs to consider, and we can provide a resource for that. So we've created a library, we call it our patient navigation program, where patients come to us and say, I'm having trouble affording this drug, and we basically walk down the different steps that we can do. One of those steps can be looking at patient assistance programs based on 340B.
So are you doing, or you will do outreach? Because, I mean, it takes a very knowledgeable person to know where some of these benefits are. So are you planning on doing, or have you done like outreach?
We have not necessarily like a full rollout. I think one of the things we're still exploring with the state is the best way to do that. And also there's a general capacity issue.
Okay.
You know, we help patients kind of on an ad hoc basis right now. So often constituents are sent to us by legislators. Anytime they come to MDH and things like that, they're referred to us. So we do help. And we are looking at how to build up that capacity because we think it's a valuable service. That
Thank you.
patients
One
use.
last question, ma'am. And so, you know, as far as the board and decision-making process, there are a lot of drugs out there. A lot of them are expensive. In this country, you go other places, the exact same medication is like maybe 1/10 the cost, you know. And so you would have to go and select, this is a board, one drug at a time to really decide what the policy would be, right? So how is that selection made? What's the thought process, and say we'll do Ozempic versus any other drug?
It's a great question. As I mentioned, there's probably, you know, there's hundreds and hundreds of drugs that are eligible under our statute. And we've left it up to each board member. So they've identified the different things that they want to look at. Sometimes it's overall spend of the healthcare system. Sometimes it's per patient spend, patient out-of-pocket spend. So each board member kind of looks at these numbers themselves and through their own priority sends the drugs that they're interested in to the board chair, and then the board chair curates a list that's proposed. Other boards have been more specific on which drugs they want to address. And the reason that our board decided to do it this way is because there's a number of different situations that make a drug unaffordable. So you can think of like very low volume. So there's like gene therapies and things like that that are, you know, 7-figure, 7-figure costs. So that is potentially an unaffordable situation. Or you can have situations where it's a drug that is high cost to the healthcare system because of sheer volume. So you mentioned some of the GLP-1s. Like if the health insurers covered everyone that's eligible for a GLP-1, it you know, doubles the drug spend as of the country, right?
So what's the GLP-1?
Oh, sorry, Ozempic. Yeah, I don't.
Oh, okay, okay, I'm sorry. Okay,
the weight loss drug.
Okay,
So there's been studies out there basically saying everyone that if you pay for cover all patients that are eligible for some of these weight loss drugs, it costs, you know, basically what we're already spending on drugs. So then it becomes just a new, so you can think of that's a different affordability challenge where like for a single patient, it may be affordable, but to the healthcare system as a whole, just with sheer volume, it can cause a different affordability challenge.
yeah. Thank you for the great answers. I appreciate it.
Long-winded answer,
Very
sorry.
knowledgeable. No, it's very good. Thank you. And thank you, Madam Chair.
Yeah.
Thank you, Senator. Do I have any other questions for Director York? Anything? I'm sure there'll be questions, and we'll probably ask you to come back for some other hearings, but thank you very much for being here and for the information.
Yeah, thank you
Thank
for your
you.
time.